Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In the series of previous lecture, I'll be starting today with another very interesting topic which you will face in your everyday practice. That is partial seizure or focal seizure, or we call partial epilepsy or focal epilepsy. This is the common terminology which is being utilized. Now, all these slides, etc., the material which I have gathered is from YouTube, from Google, from slideshare.not, etc. We see good number of time, lot number of cases of epilepsy. This partial seizure is very frequently, almost 80% of the time, seen in case of an adult, and detection of that partial seizure is extremely difficult because we miss good number of time those symptoms and signs and presentation of that particular type of an epilepsy or what we call as seizure. So we miss lot of those cases. So we'll be trying to make it as simplified as possible. Now we know that partial seizure meaning that there is a generation of an electrical impulse which are abnormal from one part of the brain, that is one hemisphere, either from frontal lobe or from temporal lobe or from parietal lobe or occipital lobe or from brainstem region. And due to this, it does not spread to the opposite side cerebral hemisphere. Hence, person is fully aware, or we call person is fully conscious. So, good number of time we misdiagnose this condition and we miss this particular variety of an epilepsy or we call seizure. You can see here there is a focus which is in one part of the brain and it does not spread to the other side. This will present to you as a partial seizure or partial epilepsy or we call focal epilepsy. Now the common terminology which is being utilized is focal epilepsy rather than partial seizure. What is seizure itself? Seizure is a time limited paroxysmal event. So it comes in episodes. Why it comes? It is because of sudden, abnormal, uncontrolled or we call involuntary, dysrhythmic neuronal discharge in brain, particularly cortex or subcortical region. And depending upon the area, if it is involving the frontal lobe area, we call precentral gyrus region, it will present as a motor. If it is a post-central or we call parietal lobe region, it will present as a sensory symptoms. And if it is involving brainstem region, then it will be presenting as an autonomic symptoms and signs. And if it is involving the frontal lobe, it may also present with an abnormal behavior. And if it is with a temporal lobe, it may present with auditory, gustatory, or even psychic symptoms. But any seizure is usually unpredictable. So it is also labeled as an unpredictable seizure or unprovoked seizure. Seizure which is usually for very short period, less than 5 minutes, and it stops spontaneously also. The old terminology was convulsions, ictus, events, spell, attacks, or fits. But now we always use the word seizure or epilepsy. Seizure is one episode, repeat episodes is labeled as epilepsy. So seizure is an episode of abnormal motor, sensory, autonomic or psychic activity or combination of this. Maybe motor with psychic, maybe motor with psychic with autonomic, etc. permutation combination. And that results from sudden excessive discharge from cortical neurons or subcortical areas. And grossly it is divided into three big groups. One we call generalized seizure, where both the cerebral hemisphere are involved or brainstem is involved, and partial seizure, which involves only one part of the brain and one hemisphere only. We'll be subclassifying further. So indirectly, epilepsy is a brain disease. It is not a single disease, but a group of syndromes. And it does not indicate recurrent seizures. Is indirectly labeled as epilepsy, but it does not indicate any particular etiology. It does not indicate prognosis. And there are many different types of epilepsy which we'll be discussing further. And there are, depending upon the spectrum of presentation, we further classify those types of epilepsy. So epilepsy by definition, two or more unprovoked seizure with more than 24 aparts, it is labeled as epilepsy. Or one seizure with a high risk of recurrent seizure is also labeled as epilepsy. And if there is a group of symptoms and signs, it is diagnosed as epilepsy syndrome. The term epilepsy is equal to seizure disorder, but seizures are not always due to an epilepsy. High risk assumed when 60% the chance of second seizure in a general population after first seizure, we call that as a high risk. So this particular group is that group where there is a 60% chance of second seizure in a person who had first seizure, and this is labeled as epilepsy. By and large, we divide into generalized and focal. We already mentioned that focal is limited to one cerebral hemisphere and one part of the cortex or subcortical region, while generalized is diffuse and it is involving bilateral both cerebral hemisphere, that is we call cerebral cortex of both hemisphere or subcortical structures. And subdivision will depend upon the etiology like genetic, structural, metabolic, infections, immune mediated or idiopathic, or we call unknown etiology. Depending upon that, it is subdivided into different groups. So you can see here the focal seizure is accounting for almost 80% of the adult epilepsy. It is limited to one cerebral hemisphere and one part of the hemisphere or subcortical region, maybe even brainstem or even cerebellum. And you can see here in an EEG, there is few electrodes is showing or few leads is showing an abnormal electrical activity, while good number of leads shows normal electrical activity. That means it is localized to one area. That's why it is also called as focal seizure. And only one hemisphere is involved. While in case of a generalized seizure, you can see almost all leads shows an abnormal electrical activity, and it will be seen in both the cerebral hemisphere. So we'll see a normal activity followed by suddenly a burst of electrical impulse seen in all leads and then stops suddenly. This is typically seen in a generalized seizure, and it will be involving both cerebral hemisphere. Means you will see in an EEG of both hemisphere abnormal electricity simultaneously, while partial will be seen in one hemisphere and in few of the leads, and other leads will be absolutely normal. This is very characteristic, and EEG becomes one of the most important investigation to confirm the diagnosis. But in a post-ictal phase or interictal phase, EEG may be absolutely normal. Hence, if EEG is taken between those two seizures, we call interictal or post-ictal phase, you might have absolutely normal EEG, and then it becomes absolutely difficult to confirm the diagnosis of seizure or epilepsy. Hence, video EEG recording becomes best investigation to confirm the diagnosis. So simultaneously, when the person is having seizure and simultaneously if EEG is recorded together, it will help you to make the diagnosis. That's why it is called video EEG recording. So this is showing you partial seizure, this is showing you generalized seizure, and this is normal EEG. So you can see all lead is having a small amount of electrical activity. There are no abnormal spikes. While here you can see an abnormal electrical activity which will last for a short period and which will subside, and it is seen in some of the leads, while here it is seen in almost all leads and bilateral. So again same, few of the leads lasting for a short period, while this is in all leads and it will be seen in both the cerebral hemisphere. So either it will be involving both cerebral hemisphere and it may start from subcortical region also, like brainstem. So seizure types, it can be focal, it can be generalized, it can be unknown, and there is one more we call as a unclassified groups. So types wise, epilepsy, again you can divide into focal, generalized, combined, which is generalized and focal, and unknown etiology. And epilepsy syndrome will be with comorbidities, with other symptoms and signs, and etiology wise, it can be structural, genetic, infection, metabolic, immune, or unknown mechanism. So we have to identify whether it is an epileptic syndrome or it is a pure epilepsy, which is usually idiopathic, where you do not come across those additional group of comorbidities or we call as secondary findings, or usually those are belonging to secondary etiology, but these are idiopathic. So idiopathic are usually we call primary epilepsy, which can be focal, which can be generalized, which can be of unknown focus, and may show you focal becoming generalized. So these are the way we usually use the terminology. You can see here the person has become unconscious. So what you have to do, you have to just turn the person on one side. He will have a tonic phase, clonic phase, followed by what we call as a post-ictal phase. While partial seizure, the person do not have a fall, and person in certain partial seizure may be unaware. We call partial seizure with unawareness, and you can have complex partial seizure where person is unaware and there is a group of symptoms where you can have stare look with automatism, etc. We'll be discussing in detail in further slides. So seizure you can divide into focal and generalized. Focal you can divide into depending upon the aware or impaired awareness, and that can be further divided into motor and non-motor. Impaired awareness can be motor, non-motor. So we call focal motor with impaired awareness, or focal motor with fully aware, focal motor with impaired awareness, or focal non-motor with impaired awareness, focal non-motor with aware. These are the type of terminology which are being now utilized. And in generalized, we have lot of groups by like generalized tonic-clonic, generalized tonic, generalized clonic, generalized myoclonic, generalized atonic, absence seizure, which was previously described as petit mal epilepsy, and generalized tonic-clonic was described as a grand mal epilepsy. And this absence seizures or petit mal seizure is further typical, atypical, etc. So you can see here, this is focal, aware, impaired awareness, and further divided into motor and non-motor groups. Motor group can be atonic, automatism, clonic, epileptic spasm, hyperkinetic, myoclonic, autonomic movements, etc. While impaired awareness can be also with any one of these motor or non-motor movements, and non-motor can be automatism, autonomic, behavior arrest, cognitive function disorder, emotional, sensory, etc. These are non-motor. So you don't see any movement of the part of the body. While in this, you see the movement of the part of the body. And during that particular person may be fully aware or may have impaired awareness. While in generalized onset, it is always impaired awareness. Person is unconscious, maybe motor or maybe non-motor. Non-motor is typical absence or atypical absence, myoclonic or eyelid myoclonia. While in motor, tonic clonic, clonic, tonic, myoclonic, tonic clonic, myotonic, atonic, or pure atonic or epileptic spasm. These are all sub-classification. The most common you see in your everyday practice is generalized tonic clonic, and as far as non-motor is concerned or absence epilepsy is typical, petit mal or atypical variety. These are most common, and some of the epilepsy are seen very commonly in children. When we don't know whether it is generalized or focal, we call unknown onset, which can be divided into motor and non-motor. And among motor, tonic clonic, epileptic spasm, and among non-motor, behavior arrest. And there is one more group which is unclassified, which does not fit with either focal or generalized or unknown onset, and that is put into unclassified. And in unclassified, we come across mainly group of disorders which is seen very commonly in children, like febrile seizures, infantile spasms, etc. So same thing, and this was classified in 2017. And what we have mentioned in this previous slide, everything is mentioned, same thing here. And subdivision can be by etiology like genetic, structural, metabolic, infective etiology, immune mediated, and unknown etiology. So that is how it is being further sub-classified into depending upon the etiology. So the old terminology as far as focal was partial. When person is fully aware, it was called simple partial. When person gets impaired awareness, it was called as a complex partial seizure. Now we use the word focal, impaired awareness, non-motor, or focal, impaired awareness, motor. Partial seizure is mentioned as focal, aware, motor, or focal, aware, non-motor. While generalized is always unaware. So it is with impaired awareness. So these are the few terminology which are being very frequently being utilized. We are going to discuss mainly on a partial seizure. The old terminology is simple partial, complex partial. Simple partial is fully conscious, so we call simple partial aware seizure. Complex partial is called as focal impaired awareness seizure. So that is complex partial seizure. And that either simple partial can become complex partial and then can become a generalized seizure, which is usually labeled as secondary generalized seizure. And this is preceded by focal seizure, or we call partial seizure. And that is usually GTC variety, we call generalized tonic-clonic seizure, and person has got altered level of consciousness, or we call impaired awareness. Among these partial seizures, 70% of the time it is temporal lobe epilepsy, and 20% of the time it is frontal lobe epilepsy. So almost we say that more than 90% of the time it is either temporal lobe or frontal lobe epilepsy, and 10% of the time parietal lobe, occipital lobe, or subcortical, which may be brainstem or brainstem regions, etc. So this is a terminology utilized in focal epilepsy, or we call partial seizure. The old terminology was this. Now these are the newer terminology which are being utilized. And it is well said that focal seizure accounts for almost 80% of the adult seizure, while only 20% are generalized seizure. So the common terminology which is being utilized for focal seizure is focal epileptic seizure, which can be further divided into focal aware seizure. This is called focal aware seizure, which can be focal sensory, focal motor, focal emotional, focal cognitive dysfunction, focal autonomic, and focal behavior arrest. Any one of these terminology is being utilized. The old terminology was petit mal, simple partial, aura, and warning signs. Now this terminology is gone. So now we use only one terminology, focal aware seizure, which is subdivided into sensory, motor, emotional, cognitive, autonomic, or behavior arrest. Second group is called focal impaired awareness seizure, is this group, which was old terminology petit mal, complex partial, and focal cognitive seizure. Now only one terminology is focal impaired awareness seizure. So it is focal seizure with impaired awareness. So that is called focal impaired awareness seizure. And then in that you can have motor, you can have non-motor, any one of those combinations. So focal seizure is 80% of the time in adult. We already mentioned 70% of the time temporal, 20% of the time frontal lobe epilepsy. And seizure, which is recurrent, 60% of the time it is a focal seizure which is recurrent, and in 30% of the time it is generalized seizure in one series, and you can have a non-epileptic seizure which can be 20% of the time. So indirectly this can be also one variety where you do not see, this is we call non-motor seizure. So non-epileptic seizure, so that will be one variety groups. So simple seizures, complex partial seizure, and secondary generalized. It is important that these two groups, that is complex and secondary generalized, will have altered level of consciousness. In complex partial, person will have a post-ictal confusion, and you will have a complex ictal automatism. While in secondary generalized, you will have a Jacksonian march, or you can have a Todd's palsy or post-ictal confusion. While in simple partial seizure, or we call focal seizure without impairment, or we call simple partial awareness seizure or aware seizure, where person is fully conscious, there is an abnormal sense of smell or taste. We usually label that as aura. Person may have a staring look without any altered level of consciousness, and person will have maintenance of posture, means retains muscle tone. Person doesn't get a fall, and that is labeled as a focal aware seizure. So person is fully aware and person is having a focal seizure. Old terminology, simple partial seizure or simple focal seizure. That was the terminology. So 80% of the time it is in adult, simple partial seizure. It can be motor, non-motor, depending upon the presentation. Person can be a motor in which a convulsive movement, chewing movement, lip smacking, etc. While in sensory variety, paresthesia, aura. In automatic, or we call autonomous or autonomic, sweating, flushing, pupil dilatation. And as far as the frontal lobe is concerned, person can have behavioral problem like hallucination, that is called deja vu or jama vu, dysphagia. Impaired consciousness is rare in this group usually. Then we call that a simple partial with awareness. So simple partial aware seizure. And when the person has got impaired awareness, then it is called simple partial impaired awareness seizure. So that is the terminology. Old terminology, complex partial seizure. So simple partial seizure, it is short duration without loss of consciousness. It can be motor, it can be sensory, it can be autonomic, it can be psychological or behavioral problem. In motor, jerky movement, twitching movement. In sensory, complaints of tingling numbness or burning sensation, etc. In autonomic, flushing, tachycardia, nausea, abdominal pain, abdominal complaint. In psychological, hallucination, anxiety, panic disorders, abnormal behavior, sudden arrest of movements, sudden arrest of cognitive functions, etc. And then simple partial can proceed to complex partial, or we call simple partial with impaired awareness, or it can proceed to what is called a secondary generalized seizure, where person will have generalized tonic-clonic seizure, and that is usually labeled as secondary generalized seizure. So this is the way it progresses. So focal aware seizure begins in one area of the brain only. Typically it is very, very brief. It is usually less than 2 minutes, by and large for few seconds. Person is fully conscious and aware of everything what is happening during seizures. Sometimes it was previously labeled as aura or warning symptoms, or it was also labeled as partial seizure or simple partial seizure. So simple partial seizure was the old terminology, where now person can have lot of symptoms like confusion, loss of memory, visual disturbances, automatism, repetitive movements of lips, smacking of the lips, chewing, feeding of the clothes, etc., difficulty in speaking, jerking limb movements, that is motor movement, sensation of fear, nausea, funny sensation in abdomen, etc. These are the common symptoms which you can have, but person is fully aware of those things. Then we call that as focal aware seizure. This is very, very typical. So person is fully aware, can have suddenly stare look, suddenly stops movements. Person may have a stare look, may have a little eyeball movements, may have a abdominal symptoms, little nausea, may have a blurred vision or eye symptoms, sensory symptoms. Person may be confused, may have a abnormal movements, picking up clothes, smacking movements, etc. This is a very nice slide which explains you almost everything in a focal seizure. This is etiological wise. You can classify according to the etiology like genetic, traumatic, syncopal, episode producing seizure, stroke, hypoxia, infection, metabolic disorders, and when we don't know any of this etiology, we call that as an idiopathic or unknown etiology. Now this seizure happens because of imbalance between excitation and inhibition of neurons, or there is a hypersynchronicity of our neuronal circuits, and it ends up in a seizure. During seizure, person can have incontinence, can have tongue bite, but this is more commonly seen in a primary generalized seizure rather than focal seizure. Focal seizure, when it becomes generalized, it is usually labeled as secondary generalized, that is partial seizure or complex partial seizure becoming secondary generalized. Now we usually mention that as focal seizure becoming focal seizure unaware motor. So that is labeled as secondary generalized tonic-clonic seizure. We are going to discuss regarding focal seizure, which is localized, where there is a abnormal generation of impulse only in one cerebral hemisphere and one part of the hemisphere on subcortical region. When it is involving frontal lobe, person can have a loud vocalization, bipedal movements, Person can have an abnormal posture where you can have an abduction of the arm, you can have an extension of the arm, and this may help you to localize the area where the focal seizure has started. So this is where it starts with a motor movement, and this becomes very easy to identify. And when from that primary area it spreads to another area, we call as a Jacksonian march, and usually it will start from the distal to proximal. So that is called Jacksonian march, and then it will exit, and this will also produce eye deviation, and this is very commonly with frontal lobe involvement. So eye will be deviated to one side pointing towards the site of damage. That is, if it is pointing towards the right side, so you have got a right frontal lobe involvement. And once this seizure gets over, person will invariably have post-ictal state, and person might show Todd's palsy, particularly when the person is having a motor epilepsy. This is classically seen in a frontal lobe epilepsy, and this is little easy to identify because person has got motor movements. But in case of parietal lobe, occipital lobe, temporal lobe, it becomes little difficult to identify. In parietal lobe, person may complain of little amount of sensory symptoms in forms of pins needles, tingling sensation, heaviness, temperature sensation, pain sensation, etc., which may be neglected because person is fully aware. So which is quite frequently neglected in the form of what we call as abnormal symptom due to sensory involvement in peripheral neuropathy, etc. So this is good number of time misdiagnose and misinterpret this parietal lobe variety of focal epilepsy. In occipital lobe, person will have a hallucination, visual hallucination in the form of bright light, colorful lights, flashing lights, visual disturbances, etc. And good number of time it is misdiagnosis, aura, or person. We say that you got some eye problem, go and have an eye checkup. So that is very commonly being misdiagnosed. And occasionally person can have eye deviation as a part of occipital lobe epilepsy. The another variety which is little difficult to diagnose is temporal lobe epilepsy, and in that person can have an aura, and in that aura person will have a usually aura which is related to smell, that is we call olfactory aura, abnormal smell, or auditory aura, quite common. Another is autonomic dysfunctions in the form of flushing, pallor, tachycardia, hypotension, etc. Or automatism. In automatism, mainly it involves the oral face, that is smacking of lips, movement of tongue, little facial movement, grimaces movements, etc. And then comes what we call as behavior and hallucination, where person will have a hallucination is described as a deja vu or jama vu, fear, and person might have dystonic movements also. These are typical in case of a temporal lobe epilepsy, and these are sometimes mistaken as even psychiatric disorders. The best way to confirm the diagnosis is one by T2 MRI, which can show you some finding in a temporal lobe in an MRI findings, and another is by video EEG recording. So when the person is complaining of those symptoms, you can have an EEG where it will show in a temporal lobe spike and abnormal waves. This is absolutely necessary in case of parietal lobe, occipital lobe and temporal lobe. While in case of a frontal lobe, it is little easy because you have got some variety of motor movements. Hence, it becomes little easy to diagnose. But again, confirmation is by video EEG recording, and that is absolutely necessary. So this shows you again the same thing. If a person has got parietal lobe, it is concerned with sensory. So it is called somatosensory, tingling numbness of contralateral limb or face or the side of the body. And the commonest symptom is burning sensation, tingling sensation, numbness, pain sensation, etc. If it is involving occipital lobe, person will have a visual disturbances and visual hallucination in the form of flashes of the light, scotomas, unilateral or bilateral blurring of the vision, etc. Bright light, dark spots, colorful lights, etc. In temporal lobe epilepsy, person will have a hallucination in the form of deja vu, jama vu, abnormal taste sensation, abnormal smell, we call as a auditory aura or gustatory aura. Person can have a feeling of fear, ringing sound, that is auditory aura, whistling sounds, some noises, train sounds, alarm sounds, etc. Those are we call auditory aura, and some abnormal sensation in a oral cavity we call as a gustatory aura. If it is a frontal lobe involvement, more commonly you will see the motor signs in the form of twitchings, that is clonic movement, tonic movement. So focal motor movement may be in the form of tonic or maybe tonic clonic or maybe only clonic. Very frequently it is involving the upper limb, occasionally lower limb. It may involve even a face, and there will be grimaces movements, head movement, eye turning to one side, particularly pointing towards the side of lesion. That is, if the person has got a right frontal lobe involvement, I will point towards the right side, and you will have a movement on the left upper limb or left lower limb. You will have autonomic symptoms in the form of sweating, flushing, pallor. These are more commonly seen in a temporal lobe epilepsy rather than the frontal lobe epilepsy. And in an EEG, you will demonstrate abnormal electrical potential during the episodes. Hence, video EEG recording becomes one of the best method of confirming the diagnosis of partial epilepsy involving parietal lobe, temporal lobe, frontal lobe, occipital lobe, etc. or even subcortical region, that is brainstem. So focal seizure can present in the form of sensory, motor, autonomic or behavior problems like deja vu, hallucination, etc. So that is the common presentation. As far as the temporal lobe epilepsy is concerned, it is accounting for almost 60% of focal epilepsy. So it is a very big group. It is associated with good number of time impaired awareness. So it is one of the classical group in case of a what we call is a complex partial seizure, or we call partial seizure with impaired awareness. And it starts in involve one or both, and then it is starting in a temporal lobe. So good number of time it is involving both, so it will become with impaired awareness. But when it is single, it may be with full awareness. But by and large, good number of time it is with impaired awareness. And in that particular group, the etiology, common etiology is head trauma, febrile seizures, or good number of time we may not be able to make a diagnosis, we call that as a idiopathic. And surgical intervention, that is temporal lobectomy, good number of time gives you almost complete cure. So this becomes very, very important in a temporal lobe epilepsy. Frontal lobe we have already described. You can have a motor movements, you can have a eyeball movements, you can have a abnormal body posturing, person can have difficulty in speech, and person can have an explosive scream, sudden laughter, etc. That we call as abnormal movements. In parietal lobe, mainly sensory symptoms. In occipital lobe, visual disturbances in the form of a visual aura, colored objects, flashes, scotomas, impaired sights, impairment in a visual fields, etc. And in a temporal lobe epilepsy, hallucination, epigastric symptoms, automatism, deja vu phenomena, etc. So simple partial, or we call focal seizure with awareness, can be motor, can be non-motor. Non-motor can be sensory, and it can be another group we call behavior problem or psychological. While complex partial is always with impaired consciousness, and that is described as partial seizure or focal seizure with impaired awareness. Old terminology was complex partial. We have already discussed Jacksonian march, which is usually focal or localized seizure, or we call focal seizure, which is motor, but almost majority of time it is with full awareness. And then later on it can become generalized tonic-clonic. It usually lasts for 20 to 30 seconds only, and it is localized to one side of the body. And in a post-ictal phase, you can have a Todd's palsy, which will recover completely within few minutes to hours. That is typical in case of a Jacksonian march. As far as the non-motor group is concerned, it can be somatosensory, it can be visual, it can be auditory. Auditory is usually seen in a temporal lobe, visual is seen in an occipital lobe, and somatosensory is seen in a parietal lobe. Vertiginous sensation is commonly seen in a subcortical region. Olfactory is again seen very commonly in case of a temporal lobe. Gustatory is again seen in a temporal lobe. And visceral sensation are also quite common in case of a temporal lobe epilepsy. This is classical description of a complex partial seizure where person has got impaired awareness, or we call impairment of consciousness. Cognitive function is affected. Person has got a stare look, we call dreamy stage, blank look, vacant expression. Person will have a hallucination in form of a deja vu or déjà vu, and also a fear appearance may be there. He will also have a auditory hallucination in the form of ringing sound, musics, or train sounds, ringing of bell, etc. Also, person will have what we call as a psychomotor movements in the form of dysphasia, means difficulty in speech, chewing movement, smacking of lips, wetting of lips, picking of clothes, etc. And if you look at the EEG, during the time of epilepsy, you will see an abnormal electrical activity in a temporal lobe, and this is showing you left side temporal lobe EEG, which is showing you an abnormal electrical activity. But this will last for a very short period. It will never last for minutes. Rarely, usually less than 2 minutes. So that is a typical, and also you can have an olfactory hallucination. This is classically described as a complex partial seizure, or we call focal seizure with impaired awareness. That is temporal lobe epilepsy, commonly seen in a temporal lobe epilepsy. So same symptoms being described here, psychomotor triads, that is motor, automatism, and psychic. That's why I call psycho, motor, and with automatism. So psychomotor triad. So you get motor symptoms, you get automatism in the form of smacking of lips, etc. And you get a psychic symptoms in the form of hallucination, abnormal behavior. Those are deja vu, déjà vu, etc. Usually person will have a presentation in the form of aura, that is auditory aura or olfactory aura. Person will have altered consciousness, or we call altered level of consciousness. We also label that as impaired awareness. Automatism is in the form of abnormal movements, oral movements, while motor movements are in the form of a facial grimaces, and it is the most common variety, that is temporal lobe, which is almost in 60%, and in 30% frontal lobe. This is very commonly seen in focal seizure, very common focal seizure. Same description, duration is always less than 3 minutes. If it is lasting for more than 5 minutes, you should be aware it may go into what we call as generalized tonic-clonic seizure, may become secondary generalized. So I am keeping this slide for a while. You can go through. I've already described repeatedly. During that complex partial seizure, what you are supposed to do, we should stay calm, track the time. That is, you try to note the time of seizure. If it is longer than 3 minutes, you should be cautious, and person may go into what we call as secondary generalized. Do not restrain the person, but help him to avoid the hazards. So see that person doesn't get injury. Remove the hard objects, sharp objects which are coming in the way, and do not oppose the person. And if the person is agitated, stay behind him and try to protect him. Check for the epilepsy, and you can record that epilepsy, and try to find out the disorders what he is supposed to have. Understand the verbal instruction may not be obeyed. Stay until the person is fully aware and help to reorient them. And only when he becomes completely normal, then only you can leave the person. Call an ambulance if it is lasting for more than 5 minutes. And if it is unknown whether the person had a prior seizure, also you can call an ambulance. That is the first aid what you can do during complex partial seizure, or we call focal epilepsy with impaired awareness. And this will be the EEG. You can see in a one EEG, you can see an abnormal activity in one lead. This is another lead. So this is partial seizure, and other leads are showing normal electrical activity. That means this is partial seizure. So simple difference between focal seizure and absent seizure. Absent seizure is a variety of a generalized seizure, which we old terminology was petit mal epilepsy, usually occurs in younger children, that is between 4 to 6 years, some says 4 to 8 years, while this is focal seizure can be at any age. Risk very commonly seen in a febrile seizure or injury, head injury, infections, etc. Tumor, those will have very frequently focal seizure. While absent seizure, a strong family history may be present. Aura is more common in focal seizure, while in absence usually there is no aura. There will be a stare look in focal seizure, while here stare look in absent seizure, because it is lasting for few seconds, stare look with eyelid fluttering is quite common. Focal seizure usually will have staring, and person with a focal seizure may have impaired awareness. Then that becomes focal seizure with impaired awareness, we call as a complex partial seizure, or focal seizure with impaired awareness, while absent seizure has got a brief interruption of consciousness but does not have a fall. Automatism is often, and it is of oral or complex, particularly in a temporal lobe epilepsy. It is quite common, while in an absence it is very rare. Occasionally person with an absent seizures may have an automatism. Duration of focal seizure is more than 30 seconds and may last for 2 minutes, while absent seizure is always in seconds, very rarely it is more than 20 seconds. Very, very rare. Post-ictal phase person will have usually little amount of confusion, and person will be able to describe what he had in a focal seizure with full awareness, while in case of an absent seizure, person do not have a post-ictal phase is not very common, and person is not aware of what had happened. MRI will show you some type of lesion in a MRI, while in absent seizure it will be absolutely normal. EEG will show you a classical abnormal epileptic electrical potential in some of the lid depending upon which lobe is involved, either frontal lobe, temporal lobe, occipital lobe, etc. While in case of an absent seizure, it will show you classical 3 hertz of spike and wave potential seen in almost all lid. That's why it is called generalized. Here the pathology is usually a focal cortical lesion, while here it is by and large presumed to be genetic etiology. Response to anti-epileptic drugs is usually good number of time refractory, and they might require a surgical intervention of, or they might require another additional, while absent seizure will response to an anti-epileptic drugs will be excellent. Only 15% of the group of people may have resistance, while here it is 1/3 will be refractory, and course is usually progressive, while here in absence, as the age advances, you might have a complete remissions, and 50% of the time there is a remissions in a short period. Generalized absence with complex partial comparison, same what we have discussed before. You can go through at your least time. So this is petit mal epilepsy, and this is complex partial seizure difference. Well, this was focal seizure, that is focal simple partial with absence, while this is absent seizures, and this is partial seizure or focal epilepsy with impaired awareness, where onset is gradual, more than 30 seconds, termination is gradual, post-ictal phase will be seen, you will see frequency weekly or monthly, and there will be precipitating factor unlikely, while in general absence it is lasting for less than 15 seconds, abrupt onset, termination is apparent, person usually do not have a post-ictal phase, and in a day you can have a multiple episodes. That is typical in case of a petit mal epilepsy or generalized absent seizures. So again, this is one difference between absent seizures and blank stare. Nothing else but this is a variety of a focal seizure where person has got a blank stare. It is longer, may be associated with automatism. Post-ictal phase is usually present in the form of confusion, and EEG will show you a focal electrical activity, while this will be generalized, and 3 hertz spike wave potential will be seen in an EEG, and it will be lasting for a very short period, while this will be lasting for a longer period. It will be focal and will be lasting for more than few seconds to up to 2 to 3 minutes. Again, same difference, that is pseudo seizures and frontal lobe epilepsy is described here. Pseudo seizures means person is fully aware, lasts for several minutes, usually presentation is bizarre, posture is usually opisthotonous, thrashing of head from side to side as well as vocation. Post-ictal confusion is usually absent, and person is fully aware. While in case of a frontal lobe epilepsy, it is lasting for less than 1 minute. Arm usually in abduction, leg movements are more common, monotonous, brief, and there is a minimal loss, and person may be slightly having impaired awareness. So that is the difference between focal lobe epilepsy, focal lobe complex partial seizure, or we call frontal lobe complex partial seizure. That is this, and pseudo seizure is a seizure where the person is fully aware, but he will have abnormal and bizarre motor movements. Now, as far as the treatment is concerned, we already mentioned first line of treatment is carbamazepine in focal seizure. Another is phenytoin, lamotrigine, and levetiracetam. While secondary line is oxcarbamazepine, sodium valproate, and levetiracetam. That is most commonly being utilized, and there is a big list of other options which is available, but most commonly we utilize sodium valproate and levetiracetam as a second line of option. This is a classical Jacksonian epilepsy. You can see the movement has started from the distal, that is finger, proceeding proximally, and you can see even the movement of the lower limb also. You can see the lower limb movement, and during that time opposite body does not show any movements, and person was fully conscious. He was also having an eye deviation to one side, and it was pointing towards the side of lesion, that is, it was pointing towards what we call is the right side, and he was having a left side movements. So that was very, very typical. It is Jacksonian epilepsy. So this was typical Jacksonian epilepsy. Now this is a focal epilepsy. Again, it has started from the face and then lips, half of the face, and you can see even upper limb was involved. So this was also one variety of a Jacksonian, but it was involving face, eyelids, and also it was involving upper limb. During that time, person was fully conscious. Now this is an epilepsy which is purely focal and localized to only one upper limb. You can see it was seen in only one upper limb, that is right upper limb. Now this is one variety of a complex partial seizure, or it is called focal dyscognitive seizure. He was narrating one presentation in a meeting and suddenly he becomes unaware. He is having little facial movements. He is picking up clothes and he stops communicating. And you can see little movements of the face. And he's picking up clothes also. You can see the movements of the lips, stare loop, smacking of the lips. He is wandering. He fiddles the clothes, or he picks up the clothes. He has got a movement of the upper limb, picking up clothes. Unusual behavior. Good number of time it is mistaken as intoxication, etc. or psychic syndromes. But at that particular time, do not interfere. See that it doesn't get injury. Remove the sharp objects, hard objects. This is classical focal dyscognitive seizures. Stay by that sides. Move the dangerous objects so that it doesn't get injury. So potential danger should be removed. And stay with him till he recovers completely. That is what should be done. Now you can see that he is still having an abnormal behavior. Now he starts speaking, communicating. Once the seizure ends, the person assure him, wait till he recovers fully. Now he is recovering. He is still confused. That's why it is called focal dyscognitive seizures. Now he is able to communicate better. This video I have picked up from epilepsy. Now this is another showing you a focal seizure, but
this video shows how to
this
help
is
if someone
typical
has a focal seizure.
where you can see now what is happening.
Focal seizures can cause lots
He's
of
giving a
different
description.
symptoms.
What is a focal
Someone having a
epilepsy?
focal seizure may not be aware of their surroundings or what
So
they're
person
doing.
can have
They may
suddenly
have
a stare
unusual
look,
movements and behaviours such as
abnormal
plucking at their
behavior.
clothes, smacking their lips,
Person
swallowing
is
repeatedly, or
unaware
wandering around.
what is happening.
Some people have strange sensations, a
Person
feeling of
can have
deja
a
vu, or
almost
can shout
appearance
or
like what we
swear.
call as a daydreaming,
Most focal seizures last between 1 and
and
2 minutes.
person is totally unaware
It's
of
not
it,
always
what is
obvious
happening.
that someone is having a focal seizure. Focal seizures can be mistaken for unusual behaviour or someone being drunk or on drugs. Let's
Now
see
she is
what a
working
focal
in one
seizure can look
particular
like
mode.
and how you can help.
These are the
Hi,
two
Annie.
persons.
You okay?
He's just
Hi, I'm
asking,
good,
how
thank
are
you.
you?
How are you?
Very well, thanks. I think that's everything sorted for this morning's order.
Oh, that's good, because David's order is ready as well.
Oh, good.
And now you will see
Is
suddenly
there
she
anything
will have a
else you
stare
need?
look.
Yeah, there is something.
Oh, yes.
Now see, she's having little epigastric
Annie?
symptoms. She's
Annie,
having
are
stare
you
look.
okay?
This person is asking what is happening. She's not able to reply.
Annie, I think you're having a seizure.
So he just,
If someone is having a focal
he knows
seizure,
that she's developing
to
some
help.
problem.
Everything's
During
going
that
to be
particular
okay.
time, she's having see little twitching
Focal
of the eye,
seizures can be frightening and
stare
disorientating for
look,
the person.
and she's
So
not
be
aware.
calmly reassuring.
Just take your time, Annie.
She's
it's
not
fine.
able to
You're at
communicate.
work in the warehouse.
She's having little movement of the
Only
lips.
intervene
You
if you
can
need
see
to
that
guide them away
chewing,
from danger.
chewing
Don't make any
movements.
abrupt movements that could
This
frighten
is
them.
very, very common in
Don't try to
temporal
bring
lobe
them around
epilepsy.
or restrain them.
Are you okay, Annie?
It is a variety of a focal epilepsy. Now you can see that she is recovering now.
Everything's going to
It
be
has lasted for a very
fine.
short period.
Seizure.
And during that particular period, after seizure, you
After
should
the seizure,
take care
stay
so
with
that
them until
person
recovery is
doesn't get
complete.
any injury.
Would you like to come and have a sit in the staff room?
Yeah.
It's this way.
Some people feel fine after a focal seizure.
She doesn't
While others
get
may feel
injury.
confused or
That
tired.
precaution you should take.
Don't give them anything to eat or drink until they're recovered.
So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. Thank you once again. Now, if you like this particular lecture, you can share with your friends. Don't forget to press button like. And if you are not subscribed, you can subscribe. You will get a bell notification. So don't forget to press button bell also, bell notification, whenever I upload these particular videos, different videos. If you find any particular suggestion, don't forget to give your suggestion so I can improve. Again repeating, this is mainly for educative purpose and this will be very useful to fourth year students as well as when you go to your private practice to pick up those focal epilepsy and prevent complications what a person is developing. You will be able to prevent those complications and person, if you detect them early, particularly focal non-motor epilepsy are difficult to pick up. So if you pick up those particular epilepsy like temporal lobe epilepsy, parietal lobe epilepsy, occipital lobe or basal, etc. If you pick up them early, in an early stage, you will prevent them going from focal seizure with awareness to focal seizure with impaired awareness, that is with generalized tonic-clonic seizure, we call secondary generalized. Because if you start treatment in early stage, you will prevent them from going to that stage to the another group and you will help the person. So thank you once again. I end my lecture here. See you in next lecture.